All right. This talk is also kind of lacking in evidence, but we'll give it our best shot. So, thinking about depression in ASD, studies that have tried to get at prevalence do find higher than average rates, anywhere from 17 to 44%. And then, like anxiety, there's no published drug trials relating to depression as a primary outcome. We might see this more commonly in individuals with higher intellectual ability and greater social awareness. We talked some about that in the anxiety talk. Again, we're stuck with this problem of how to measure depression and mood symptoms in people who are less verbal. So it doesn't mean that it can't exist or doesn't exist. We may be not so great at detecting it. So what are some of the risk factors specific to this population? We see high rates of social rejection and social isolation, and kids who are more aware of that are more at risk for depression. We see these kids have a lot of academic difficulties, so trouble with school can definitely be a stressor. We see kids, and I think especially in adolescents and young adults, who struggle with their adaptive living skills, who developmentally want very much to be independent and really struggle to achieve that and to be independent, so they still depend on their parents, but yet want to be independent of their parents, and I think that creates a lot of tension and stress for our adolescents. Just a bit about the challenges of identifying depression and autism. Like with most of these symptom clusters, we see a lot of overlap in the symptoms that make it really difficult to tease out depression from autism. So we might see that nonspecific irritability for a whole host of reasons. We might see reduced or flattened affect. We know that's a feature of autism at baseline. Social withdrawal, limited or few interests, and sleep disturbance. So that's, if you look at just those symptoms in isolation, that starts to sound an awful lot like depression. So we also see kids who have trouble recognizing emotions in themselves and in others and describing those emotions, almost like an alexithymia. We have language impairment, and we have no good autism-specific rating scales for mood. There is one scale that's used pretty commonly now in neurodevelopmental disorders research. It's the ADAMS. It's the Anxiety, Depression, and Mania scale. And it's specifically designed to capture mood symptoms in people who have intellectual disability, but I don't think that has filtered into clinical practice. All right. So here's just one general approach. We know that these kids are at higher risk, so we want to screen for depression often, and particularly in those who are capable of giving us self-report. Also, in individuals who may be less verbal or less intellectually able, we want to think about a decline from baseline functioning. So particularly with those symptoms that overlap autism. So if we, it's not enough to have social withdrawal at baseline, but if there's a change in their level of social interest, if there's a change in their verbal output or their language, or there's a loss of interest even in the things that they used to like to do, that could be a sign that this is a child experiencing a depressive episode. I did emphasize family history here because many of the kids who I've seen and suspected depression in often have a family history of mood disorder and depression, so I use that as one of my clues about and trying to stratify risk and thinking about how likely it is that that's what we're dealing with. Because we're lacking in medication research specific to autism, CBT with a social skills component is generally considered to be our first line treatment, especially for mild to moderate. And then for anything more severe, especially if there's suicidality, then we follow our treatment guidelines for pediatric depression. There's really not a single study pertaining to medications for depression and autism, even as a secondary outcome.
When you're saying categorically no studies?
Nothing. I mean, CBT, yes, but nothing related to medications. That's right. I just highlighted here all of the SSRIs that have some approval for use in children, not specific to IDD. But the two that have approval for pediatric depression are fluoxetine and escitalopram. And I haven't had a chance to look at the depression guidelines, but we might want to take a look at those and think about how they line up with those recommendations. All right, that was depression. Any questions before we talk about bipolar? No? Okay. Here again, there's kind of a paucity of research. The prevalence seems to be somewhere around 5 to 7%. Again, this is a challenging thing sometimes to identify and diagnose, particularly when there's intellectual disability and language impairment. There's not a lot of agreement between what we get from things like claims data, so community diagnosis, versus structured interview. So usually when there's some structured interview administered, those rates of bipolar disorder are going to look lower than what we get when we're looking at just rates of diagnosis. And often, this is, I think, mood lability and irritability in particular may get misdiagnosed as bipolar, either by clinicians who may not have as much familiarity with autism, or just sort of a misinterpretation by families, because there is so much in the media, particularly about irritability and chronic irritability and mood swings representing bipolar, that has kind of filtered down to our community as well. So I think most people would advocate that we should apply the standard diagnostic criteria here when we're trying to evaluate bipolar disorder. And so that really means, to me, eliciting for mania-specific symptoms, things like a change in mood where it's especially elevated or euphoric, where there's an increase in goal-directed activity, and then trying to use the best tools that we have available to screen for those symptoms. That could be something like the Young Mania Rating Scale or the ADAMS. I included one case illustration here because I have had one patient that I really felt had both. And so this is just an example of how I kind of arrived at that idea. This is mostly true. I've changed some details, but I saw a young man who was 21 who had autistic disorder, intellectual disability in the moderate range, language impairment, and seizures, who on history had these previous periods of lethargy where he was sleeping a lot, he would get irritable, he didn't want to go to school, he didn't want to participate in activities. And before he was transitioning into a group home, when he was finishing he was finishing high school, going on to the group home, he became more agitated than usual, where he was very hyperactive, he became loud, his speech was repetitive at baseline, but it became rapid and it became constant. He was not sleeping. He had this increase in sexual drive, as best we could tell, so he was rubbing his privates against female caregivers at the group home. His outbursts became more unpredictable. On family history, his father had bipolar disorder, but very well controlled on lithium and seizures. His paternal grandfather had also been diagnosed with bipolar disorder, and we did a lot to try to get him stable. He eventually responded to 2 antipsychotics after not doing well on one antipsychotic and Depakote. And we had discussed lithium. I think this family had some reservations about treating him with lithium when he wouldn't be able to give good report about some of his physical symptoms. But this was one of the rare cases where I really felt like there was a good case for there being two processes happening. The timing, so he was about the right age for a first mood episode. He'd had clear changes from his baseline where there were symptoms that could be consistent with depression and symptoms that could be consistent with mania. That increase in sexual drive was one of the things that was sort of a red flag to me as being different than his usual behavior. And the family history was pretty compelling too. Okay, So there are no controlled trials of medication for bipolar and autism. There was one chart review that I found by Matt Siegel, who's up in Maine, who does a lot of inpatient work, and they did find lithium helpful for manic symptoms in autism in their sample. They included 30 kids. A little less than half were responders to lithium. My general approach has been, again, to follow guidelines for treating bipolar disorder in youth who don't have ASD. I put in here a caveat that risperidone and aripiprazole may be preferred among those options because they've been well characterized in autism, but not specifically for this indication. Okay, there has been one study that just trying to characterize bipolar disorder in children with autism. So this was the COBE study was this outcome study for youth with bipolar. They did have a subgroup of 30 children who met diagnostic criteria for both ASD and bipolar. And what they found was that there were, the severity of their lifetime episodes were similar. Kids with autism also had higher rates of ADHD and OCD. Their mood symptoms seemed to have an earlier onset. They had lower rates of suicidality, and they had more prominent distractibility, racing thoughts, depressed mood, social withdrawal, and mood reactivity than the cohort with just bipolar disorder. And they were more likely to have subsyndromal symptoms between mood episodes. All right. So these are our mood recommendations from 2017. Level 0 was to screen for mood symptoms and consider mood as a possibility when there was a change from baseline functioning and mood symptoms. Level 0 was looking at family history. I guess I don't know why I included those as two separate bars. Level 1 was to follow, extrapolate from our treatment guidelines for depression and bipolar.